Hello, dear colleagues. My name is Nikolaos Papadopoulos. I'm a professor of allergy at the University of Athens, and I would like to thank you very much for the opportunity to present to you about allergies, quality of life, and sleep. These are my disclosures. And I presume that not most of you will not be specialists in allergy, so I thought about giving you some context into how this condition first appeared. It is interesting that one of the first cases that were described were that of John Bostock. Himself, he presented as a case study, and because he had the problem himself, he tried in his career to find out whether there are other people that had this. So he managed in the course of about 10 years to identify 28 individuals. He stated that the condition appeared only during the last decade and it affects only the upper classes. But of course, allergic diseases have been increasing ever since. You can see here on the left different studies that happened in the same groups at different points in time. There's always an increase. And on the right side, you can see the prevalence of asthma around the world. And you will see with these red stars that in many places, it's more than 20%. So allergic diseases are currently a major public health concern. And there is an open question on how this allergy epidemic happened. What are the reasons behind it? There is a number of hypotheses that have been put forward to try to explain this. It's not only the allergic diseases, in fact, lots of different inflammatory diseases which are related to allergic diseases in terms of the immunology have increased as well. But allergy has been the one that has increased more steeply. And most of these hypotheses have started in order to try to explain allergy, starting from the hygiene hypothesis, suggesting that because we are not exposed to enough microbes, our immune system is not trained well enough, going ahead into the biodiversity hypothesis, stating that it is in fact the diversity that is lost. And this is what makes our immune system not responsive enough. Then going into the old friend hypothesis, suggesting that within this hygienic environment, what happens is that we're losing specific microbes with which we have co-evolved, and therefore we can't have the functions that these microbes were destined to play. And we have coined the incoordination hypothesis, suggesting that it is the rate of exposure that has changed. So the host, we are expecting a different rate of exposures and we get something different. So our immune system cannot react properly. One way or the other, all these hypotheses suggest that our reaction to external triggers that can include allergens, but also viruses and other irritants like smoke, induce inflammation. And they induce inflammation at different levels, at the level of the skin and the epithelial barrier, which is very important, and it is defective in all allergic diseases, and at the second and third line of defenses from the innate immune response and also the adaptive immune responses. So inflammation is central in allergy, which is a systematic immune disorder, and these cells, these immune cells that make this wrong recognition, are moving from one organ to the other. So we have the defect on the barrier, and together with the defect of the barrier, we have these specific cells that augment the inflammation. So from the allergist's perspective, allergy is a long-term immune dysfunction which causes inflammation, and it includes a number of conditions that are quite known, like asthma or rhinitis or eczema. But I think what's important in terms of information, it has also an importance in terms of the effect on quality of life, is the fact that allergic diseases, because of this common pathophysiology, they coexist very frequently. So the patient exceptionally has one condition, but they do have two or three, and also there is a possibility that they might have one condition that evolves into another. So the impact is actually multiplied by this coexistence and comorbidity. But let's start from the allergy that happens most early in life, which is atopic dermatitis or eczema. That's a chronic and intensely itchy skin rash. The skin is dry and inflamed, and there's a vicious circle of itching and scratching. So you scratch because you itch, and then this scratching induces even more itch. About 1 to 3% of the population suffers, and it has increased. It's one of the things that has increased quite a lot, tripled in the last 30 years. It is a condition that most often appears very early in life, in the first months of life, which is also very important in terms of quality of life, because it affects the relationship between the infant and its parents, the infant and the external environment. Condition can be stable for some time, but generally follows a course which is variable with flares in different times. Now, the mechanism behind atopic dermatitis is very close to what I've described generally about allergies, with the barrier being disrupted in the skin. So we have, in some cases, specific proteins that keep the keratinocytes together, keep the skin together, and there are mutations that affect it, particularly filaggrin. And the inflammation, which is induced because of the defective skin barrier, is augmented significantly by the allergic mechanisms, the typical allergic mechanisms, which lie just down from the skin. And with all the inflammatory mediators that are produced, you have a direct effect on sensory nerves that bring the message to the brain that there is something that they need to remove, and then the reflex of itching. Coming to the quality of life, which is the central point and important in this talk, the quality of life of people with atopic dermatitis, with eczema, is really severely impaired. Among the different pediatric diseases, generalized eczema had the second largest impact of quality of life, just after cerebral palsy. So it really affects the quality of life, and not only of the person himself, but it expands to siblings and to caregivers. It is very loud, actually, in the life of the family. When the child doesn't sleep, nobody else sleeps. So the impairment specifically correlates to the severity of the disease, to the amount of itchiness, and to the sleep disturbance. So sleep is central in the impairment of quality of life of atopic dermatitis. And you can see here on the right that the more severe atopic dermatitis you have, so you go from mild to moderate to severe, you have a significantly increased proportion of patients that had a severe sleep impairment as well, both the disturbance and the impairment. And there are different neuroimmune mechanisms which contribute to sleep disturbance in atopic dermatitis. The transepidermal water loss is increased during the night, so the skin becomes drier, and different cells that contribute to the inflammation are activated. They produce some cytokines which activate other mediators that increase itch directly. So you have an increased level of itch during sleep because of the hyperproduction of these mediators. IL-31 is central in itch, but also IL-6. But there is also a mechanism which is related with central signals, a phage shift in cortisol, so a disruption in the circadian rhythm, and increased production of melatonin, increase very much inflammation, together with all the other factors that contribute to increased inflammation. And this increased inflammation is associated with reduced sleep and with increased itch. And now the condition that is considered more serious, let's say in allergy, is asthma. It's a chronic inflammatory disease of the airways. It appears with recurrent episodes of cough, wheeze, and shortness of breath, and it's characterized by persistent inflammation as well. Lung function is affected, so the airways are obstructed, and in between you have airway hyperresponsiveness, which means with very little stimuli you have a lot of obstruction. So it starts quite often early in life, but it's difficult to diagnose, and people try to avoid diagnosis actually before the age of 5. And the clinical presentation, although the general description can be the same, but the different clinical presentations are quite different, distinct between themselves. We call them phenotypes. You can see here on the right, different phenotypes depending on the main apparent trigger. And this is up to 10% of the population in Western society. So it is quite frequent. What happens in asthma is that you have an already remodeled airway with hypertrophic smooth muscle, with lots of collagen and a thick basement membrane, and with different triggers. You have mucus and cell debris, you have increased edema and bronchospasm, and this generates the obstruction that is translated into shortness of breath and wheezing in the patient. Asthma is not a killer, really, although sometimes you can have, like here on the left, you can have completely obstructed airways and a person dies out of asthma every 10 minutes. It's not too much in comparison to the hundreds of millions of people who suffer across the world. However, the effect is very strong in quality of life. And it is affected even in mild and moderate disease, but severe disease has a much higher burden. And you see here on the right, the different domains that affect quality of life more. And the first one is disease control. So here you have a correlation between control of the disease and quality of life score. And you see here that this is the lowest level of control, which is more symptoms, with the lowest level of quality of life. And in reverse, in relation to exacerbations, to events of the disease, which are life-threatening. And you have here at the level of about 4 to 5 exacerbations where you have a significantly reduced quality of life. In contrast to, for example, lung function here, where you see there is some kind of correlation, but not very strong. So sleep quality is affected considerably in asthma. In a study with more than 1,000 adults, asthmatics, almost 60% of patients had poor sleep quality with a PSQI more than 5. And you see here that this was related very much to the level of control. Totally controlled was not that much affected, well controlled, but uncontrolled asthma was the one that had very, very bad sleep. And apart from severity, from control, severity, and the comorbidities, which are part of asthma as well, like rhinitis, correlated with sleep quality. In another survey, again with a large number of people, 2,800, you see here that sleep was only second among the different elements that were affected in asthma, the different activities or sports, etc. This is a really interesting and great study where it has tried to differentiate the effect of asthma in relation to the circadian rhythm and to sleep. So they have followed patients during their everyday lives, the normal sleep and awake pattern. And they have also followed the patients in an occasion where they did not sleep completely for a whole night to see whether there was an effect from a circadian rhythm or from sleep itself. And then they tried to desynchronize sleep by taking patients through a 28-hour day for a few days. And by using all this data, they generated a model trying to understand which part of whether it was sleep or circadian rhythm affected the quality of life and the pulmonary function. Sorry. You can see in this middle graph that, as we know, the number of inhalers of the activity of asthma is actually higher very early in the morning, just when people sleep, and also when they go to bed. And in fact, it wakes them up a few times because asthma is, due to circadian rhythm, affected during the night. But here you can see that the effect is maximized during the evening. And when you have a misaligned sleep from the morning day cycle, you have significantly less effect because you have both a circadian element and a behavioral element which has to do with the choices on when you sleep or not. Now let's move to the condition that's more prevalent. It's rhinitis or allergic rhinitis. It affects up to 25% of the population, and it's usual nasal symptoms after allergen exposure, most often during a pollen season, but in many cases it can be yearly. Again, you have a lot of different overlapping phenotypes, and it's a disease which affects usually young adults. Now, generally, allergic rhinitis is associated with important impairment in vigilance and in cognitive functioning. So here, in a number of tests that people with allergic rhinitis were taken during an asymptomatic period and during a symptomatic period, you can see that lots of activities like accuracy in response to queries and number of correct hits all the time, or how many mistakes they've done, is significantly increased when people have symptoms. They cannot breathe well, and they're having symptoms, and they become sleepy. Sleep impairment is one of the major problems, the biggest problems in people with allergic rhinitis. You can see here in teenagers that 64% of the population wake up during the night. 75% are able to get to sleep, and almost 80% have a lack of good night's sleep. And this together, so both sleepiness during the day, but also the lack of sleep, affect very much the performance here in the right, in terms of exams, in terms of school. It's also for adults in terms of work. Here they have found that there was a 40% increased chance of dropping a subject if a person had allergic rhinitis. And what is impressive and also mostly problematic is that many of these people will actually be receiving antihistamines and first-generation antihistamines, which they shouldn't have been using, but they are quite common. And when you use a sedative antihistamine on top, then the risk of not performing on dropping a subject increase at the level of 70%. In addition, rhinitis is a risk factor for sleep-disordered breathing through a number of inflammatory mediators. These are, to a large extent, the mediators that we mentioned before that affect both inflammation, allergic inflammation locally, but also have an effect on circadian rhythm and on sleep, like, for example, interleukin-6 or interleukin-10, which are highly increased in rhinitis. But of course, the effect of sleep is also infectious, in quotes, and it's cumulative. Here, in a study, they assessed the effect on sleep of caregivers in patients that had either atopic dermatitis alone, or asthma alone, or both. And you can see here when it comes to latency of sleep, then asthma actually was considerably impaired. Atopic dermatitis, not so much. When it comes to total sleep time, it was, in fact, atopic dermatitis that had a major problem. But when a person had both atopic dermatitis and asthma, they had a problem in both these aspects of sleep. So in conclusion, allergic diseases, which include atopic dermatitis, asthma, and allergic rhinitis, have exploded during the last couple of centuries. They are now very highly prevalent. They persist across the life cycle. They have a profound effect on the quality of life of patients. And a key element of quality of life impairment is sleep disturbance and deprivation. Symptoms of the underlying disease, like congestion in rhinitis or itch in dermatitis, inflammatory immune mediators and neuroimmune interactions are contributing to sleep disturbance. Disease severity and multimorbidity are major risk factors which multiplicate the problem. Therapeutic interventions improve symptoms and quality of life, but of course, we need additional insight and intervention to focus on sleep. And with that, I would like to thank you for your attention.